everybody. This is Dr. Avinash Jayaswal. I'm Chief Medical Officer of CCM Health. Thank you for joining us on our live podcast today. We will be joined very shortly by our guest, who is Dr. Manijeh Berenji, who will be our guest for half an hour of the podcast to talk about care plans, care plan sharing, and the strategy that goes into patient care. Before we embark on the podcast, we will make it a habit, and today will be the first time when we announce it this way, that we will get a regulatory update with our advisor on compliance, regulatory and value-based medicine. And this is Dr. Baran Erdik, of course, and he is the CMS person at the state and federal level for one of the states in the South, and he's our advisor. And today he will be talking to us about what's new on the regulatory landscape. Dr. Baran?
Hi, Dr. Avinash. Nice to see you again, and I'm glad we'll be here every 2 weeks with you, talking about regulatory updates, because believe me, there's constant changes. So today I wanted to mention two of the trends that I've been noticing over and over again. And recently, one of them has been the price transparency, right? So this has been sticking since the Trump administration. They finalized the proposal requiring hospitals to disclose charges for items and services that would be accessible online, including the negotiated rates for payers in 2019. And even though we have a completely different administration now, it's been sticking. So I can guarantee you that this is here to stay. And what's been happening with this is that there's been a lot of pushback, and some hospitals have not been happy. There's been also lawsuits and fierce opposition from hospital groups because, I mean, if you're a big hospital, right, do you want to spill all your beans, what you contract with one insurance versus the other? You don't. It doesn't put them in a competitive perspective. But from a quality metric and what we always discuss with you, right, value-based medicine metric, it is needed because you cannot have these charges as a black box, you know, whomever charges what goes. So CMS has been pushing a lot. So
yeah, transparency. Yeah.
Exactly. So two hospitals in Georgia have been fined, actually, Northside Hospital Atlanta and Northside Hospital Cherokee. So they have been fined a lot, and it's an interesting fine. If you actually read the CMS brief, is that they are actively not complying. So CMS met with them several times, and they have issued warning letters. They've tried to put them on a plan of correction. At first, both hospitals stated that they were trying to comply, that like a person, if they were interested in the charges, could email them and get what it was. But ultimately, what it turned out to be is that they were actively told by a SIM higher administration to not comply. So currently, these fines are about over $1 million. But if they do not comply, they will continue to accrue fines. So I don't know. My big worry is, I guess, from a hospital standpoint, they may be thinking that what if we just pay these fines and don't make everything public? But then that goes against the roots of a compliance or regulation, right? Like, can you actively pay your way out of it? Because this had happened previously with regards to EMTALA. Some people were actively thinking it may be cheaper to pay for the EMTALA fine than to actually provide the care. And the fine costs, et cetera, were jacked up, and it was made like significantly harder to not comply. So it's going to be really interesting here whether hospitals will start complying or not. And with that, there was a recent study in JAMA that had analyzed over 5,000 hospitals actually in the US, and only 6% were complying with this regulation. So it is going to be interesting with the next couple of months whether this is to stick. And my gut feeling is that CMS will start pushing this for other things. There's going to be more and more price transparency coming down the line. So that means if you are a small provider in a clinic, or if you are somewhere like a private care facility or a primary care physician, you may at some point have to comply with some sort of price transparency as well, will be my thinking.
This thing about, being cheaper to pay for the fine than to comply, that's like something that's been going on since such a long time. Isn't there like a better way to do this than to put fines that are payable?
In my opinion, it should be, and then it's ultimately the strength of the federal government. It's just mind-baffling to me that the hospital system can tell CMS that they have been actively told not to comply with this. It is ultimately the law of the land, and it is ultimately a federal regulation. You may not agree with something, but then your right is to sue. Your right is not to comply. And this has been ongoing with two very different administrations, both the Trump administration and Biden administration. So it's just mind-baffling. But they have been fined, so we'll see what happens, and we'll see if anything comes out of the JAMA study showing that most of these hospitals are not complying.
I think if you put the money where the mouth is, if you close the tap, that kind of maybe bites more than to, hey, you have $1 million fine, but then the turnover is $1 billion, so it's like less than 0.1%. Whereas if you
Correct,
put strings,
that's the typical care that CMS has, right? So if something happens, usually a hospital or a facility or anything is put under 30-day termination notice. They're like, either fix this or we're terminating our contract. But with the way the hospital transparency regulations were written, that wasn't necessarily an option. So my thinking is at some point they may say, okay, we're just going to put you on a termination notice if you do not do this. So that's the major enforcement.
Mm-hmm. What about the skilled nursing facilities? You talked about hospitals, right?
So correct. So talking about hospitals and skilled nursing, I like to think of the skilled nursing facility as the tail that wags the body, right? So it's basically if something happens in a SNF, that'll ultimately trickle down to even the smallest primary care provider in the smallest town. It's just the way it works, all the regulations and everything. That's SNF first, then everything else second. So with SNF, they are considering, the CMS, the current administration is considering a requirement that the over 15,000 nursing homes spend the bulk of the money they get from Medicaid on direct care for the residents. So there's been a limit on the amount that's been used for operations and maintenance and capital improvements and diverted to profits. So they were taking Medicaid money and diverting into profits, just minimizing everything. So they are thinking and they are requesting public comments on direct care spending mandate. A couple of the states have enacted this, among them Massachusetts, New York, and New Jersey. They require, for example, at least 70, 80, depending on the state, of the money they get to be used in direct care. And this is, I think, a response to just hideous like understaffing and everything going on even before COVID. And New York capped the profit at 5%. And they are also promising boost in Medicaid payment to facilities that comply with this law. So basically, there's the push is that if you're taking public dollars, those dollars be put back into direct care. And I think this is, again, value-based medicine, because what's the goal here? If you're taking the money, you need to show for it. You need to show the quality for it. You need to show that these patients with chronic care issues or whatever issues are taken care of. You cannot do the bare minimum and build a bare maximum or whatever is allowed to be the maximum and then pocket the change. That shouldn't be the goal here.
Explain a little bit to our viewers, because even to me, I can't see it so clearly as the MIP score is for providers. Is there something similar for those facilities?
For nursing homes, not necessarily. There is no MIP score. There may be for the providers that are in these nursing homes and everything. But the issue has been that there's a lot of regulatory requirements for these nursing homes, and a lot of them get cited and fined and cited and fined. But it's not like there's a lot of alternatives, so you cannot necessarily close them down that easily or terminate their contracts that easily. So ultimately, it boils down to what can you really do, right? So you keep finding them, but it gets to the same question. Are they going to be able to fix it or not? So I think with this, they are saying, okay, if you're taking the money, then you need to spend this much of it on direct patient care. So that way, at least you're trying. You're not like a free-for-all pocketing the most of the money from your right to the left, because including the skilled nursing facilities, they have been all being purchased out right and left. So it's all, everything's becoming big business.
So, this is purely for a regulatory update, but in order to situate a little bit, so like for instance, our performance metric is pretty simple. We work on the cost savings that we can generate using all the tools we have. At the end of the day, it's value in terms of cost savings. What about them? Do they have? Is there a way they can also be asked to show cost savings?
I think in the future, yes. So I'd like to think of it as the Affordable Care Act's medical loss ratio provision, right? So healthcare insurance companies must spend at least 80% of the premiums on beneficiaries' medical care. So I think the way this will plan out in the next several years is that some of these will become per member per capita. So if you have a resident you're providing care to, and that resident is not getting their insulin on time, and ultimately that resident turns out to go into ketoacidosis or non-ketotic diabetic hyperosmolar state or whatever, and they're hospitalized, that facility, in my opinion, should bear the cost of that. And I think we are slowly getting there.
Okay, so here's an idea. You can maybe propose it to, I don't know who's the secretary.
To the higher ups, right?
Tell us a little bit about Medicaid. Anything new in that area?
I mean, this is the latest from a skilled nursing care perspective and Medicaid. Other than that, we are still waiting for the public health emergency to be terminated.
Okay.
And once that does, there will be a lot of people suddenly becoming ineligible for Medicaid, especially dependent on the state if they decide to go back and do a deep dive, or if these people were qualified properly or not qualified properly. So that should be on the lookout for every physician, that suddenly 5%, 10% of whatever patients they're seeing may suddenly become uninsured.
Give us what are the states that are where most likely this might have an impact? New York?
I wouldn't think so. I would think more the states that haven't necessarily expanded the Medicaid, because in those states, this public health emergency has sort of played like a Medicaid expansion. And some of the states like North Carolina, et cetera, have been trying to pass it. Some did, some have not. But when the public health emergency ends, there will be about 10 to 15 million people that will be just suddenly uninsured.
This is across the country?
Across the country, correct. So I keep saying this, providers should be ready. If you have patients on Medicare, reach out to them. See if there's a chance that their Medicaid will expire suddenly. Then try and work with them, because there's Affordable Care Act is still the law of the land. So there's still a lot of good policies on the marketplaces, as well as there's a lot of rebates and tax promos and stuff. So people immediately think, I can't afford this. But if you've been in a financial position to qualify for Medicaid, even under the public health emergency, then probably your out-of-pocket cost for a marketplace plan should be relatively low.
Okay. That's fair enough to know that if it does come down to that, the rates are pretty low for that category, right? Okay.
So I guess to sum up, 3 things to take away from this regulatory review from today. One is that the financial transparency rule is here to stay. They're trying to enforce it, and we shall see what happens with the recent fine. Second is that there's a lot of patients that are on Medicaid that are unfortunately going to be uninsured. So if you have any Medicaid patients, now is the time to reach out to them to see if they will be affected by it, because suddenly they may be uninsured. And number three, Medicare, CMS is thinking of enforcing patient care requirements from a financial standpoint to nursing care facilities. And if this happens, which I'm sure it will, slowly this will trickle down to other providers as well.
Absolutely, and the sniffs are kind of like the thermometer.
The tail that wags the body, exactly. If something happens in a sniff from a regulatory perspective, it'll trickle down to hospitals, it'll trickle down to single providers, it'll trickle down to primary care providers.
Gotcha. Excellent. Thank you for those insights, Dr. Erdik. And we'll see you again in 15 days.
Thank you. See you, Dr. Avinash.
See you. So, how a care plan-centered strategy is precursor to good clinical outcomes, I have the pleasure to have our guest of this podcast today, Dr. Berenji, who is advisor on our CCM Health Advisory Board for clinical outcomes. She is double board certified in occupational and environmental, as well as preventive medicine, as well as a practicing physician in Southern California. I have the pleasure to have Dr. Berenji.
Yes, I am here. It's so nice to be with you, Dr. Jayaswal.
Good to see you again. From our last podcast, which has been, I don't know, it was not summer yet. So good to see you in the summer now.
Absolutely. You know, this is a great time here in Southern California. And honestly, it's a pleasure to be with you to talk about care plans.
Absolutely. Great. Let's dive straight into the subject. So care plan, centerpiece of the patient journey. That's where a lot of information is put coming from the physician, because, of course, if we look at population health for a second, so we have in our model a nurse that does the care of the patient. So he or she will look at what the physician has as instructions and then carry out the care planning. And that document is updated every time there is an interaction. And then going forward, that document is loaded with information and agreements which the nurse will be having with the patient going forward. So talking about that, tell us a little bit, in general, care, what is the winning formula?
Yeah, I mean, honestly, that's the biggest question that we all have. How do we have a living, breathing care plan that not only checks off the boxes, but really embodies what's happening to that individual patient? Really, at the end of the day, it's about having trust between the patient and the nurse or provider giving that service. You know, we want to be able to reach the patient where he or she is. You know, being able to understand their socio-environmental, components. You know, where do they live? You know, how do they interact with their family members and community? Are they able to get around without assistance? You know, really kind of getting to the basics when it comes to patient care. You know, we're not just, checking off boxes left and right to meet some objectives. We really care about these people. We want to care with them, not just care for them. And really having that sense of commitment to these patients is an essential part of the care plan.
Absolutely. So speaking of, I mean, you brought the word trust is so important, right? I mean, in care especially. So our nurses have a very, I would say, playful way to do the care, because, you're talking about our patients, most of them are geriatric. I mean, these days above 65, somebody who's 65, can you call them geriatric? But you get the idea. So, but even then, so having a playful way, it engages, and our engagement rate is very high. I'm very surprised at the numbers. We have over 90%. And when it drops down, we make sure that number comes back up. And the way to do that is, of course, trust.
Absolutely. Trust is essential. And the fact that you have that high rate of engagement with your patients, that speaks volumes about CCM Health. Really, at the end of the day, it's being able to connect to that patient where he or she is. And a lot of times, people might be doing great, everything's going well in their personal lives, their family lives, their medical lives, but sometimes things may not be so great. So being able to connect with these patients through the continuity of care, I think that's a key component of delivering good outcomes for the patients and for the practice.
Absolutely. So this is all about value. So, but you cannot even begin to do it if you don't connect. And the idea is to have this microcosm around the patient. So we try to make up for what could be, we can't reach the patient, so we have like a list of 4 or 5 phone numbers around the patient. The caregivers can be like family members, son, daughter, whatever, spouse, sometimes a neighbor, sometimes a friend, and those people are also in the list. This way we can contact them if we can't reach the patient. The idea is to meet that goal of seeing of that regularity and the appointment at exactly the same time on the same day of the month. The nurse makes the calls. This way there's
Absolutely. You bring up some key points here. So continuity of care and being consistent, making sure that you're able to reach that individual patient with whatever media is best for him or her. And then really making it a team sport, including the family members, the spouse, the neighbor. The patient doesn't live in isolation. The patient is part of a community. And being able to have that community of individuals who are part of this person's life and making sure that that nurse or provider is able to reach out to all parties involved, that really does deliver in the long term. If there's an issue with mobility, for instance, if there's been a fall, we want to be able to identify those things as quickly as possible. And by having that ability to connect with not just the patient, but all the other members of that patient's community, we can ensure that we're delivering good outcomes for everyone.
Absolutely, yes. So teamwork is great, right? I mean, even tennis or even golf is a team sport. You have
Exactly.
There's a lot of backroom staff, and a lot of it that happens in the back room is what matters. And so, absolutely, the teamwork is very important. And we're talking about. It is a challenge, and that's where we leverage our nursing grant, which is where we bring in very high quality of individuals. We have nurses doing it. And then we also have the chronic care management EMR, which is focused on the population health. And it really complements what your medical EMR is not able to do, which is population health.
Yes, really it's bringing the technological capacities that the EMR brings with that patient-centric model. When you actually coalesce those two concepts together, that's how you are actually able to have a well foundation for population health.
Mm-hmm. Totally. Let's talk about the goals. How can the patient and the caregiver achieve the goals in the care plan?
Yeah, so really the first step is that the nurse has to establish contact with the patient and making sure that the nurse is able to get that assessment. Being able to go through, what the patient currently has in terms of medical conditions, understanding the medications. A lot of our patients over 65 are taking more than 4 medications at a time. So being able to actually understand what they're taking in real time and being able to update that medication list in real time is essential to making sure that the patient is getting what he or she needs on a daily basis.
Absolutely.
And then really just understanding the day-to-day of the patient. What does the patient do for fun? What does the patient have difficulties with? This is a living, breathing document. I really want to emphasize that. The care plan is all-encompassing. It's patient-centric. It's really getting to the bare bones of what makes that patient tick. And, if a nurse or provider is identifying issues during that assessment, this is the time that the provider or nurse can really address it, and setting those expectations for the patient as well as for the rest of the nurse team to make sure that the patient is getting what he or she needs.
Absolutely. And very important. So the idea is to work to of course, we care for the patient, but with the patient. That engagement. And our model is very effective when the engagement happens. So if, for instance, we have a patient suffering from dementia, the model might not be able to, because the idea is to engage the patient. So, which, it's like self-fulfilling. So we are dependent on the engagement, but then the engagement is important by itself, right?
Yeah, I mean, really, that's the key piece. And if anything is not, adding up during that encounter, the nurse has the prerogative to bring additional players into the game, whether it's getting that neurological consult, being able to do in-person visit, being able to escalate as needed if there are concerns about the patient's neurologic or cognitive function.
Absolutely. Fall assessment. Something which is routine. Depression screening is something which is routine. We have the 2-question and the longer questionnaire as well. And all this is in the context of evaluation also, because there's the instructions, but then the nurse can herself kind of add into what she thinks is, that's what you're saying, right? To monitor and review what has been prescribed. So it's like it's like a second gate, if you will, before the playground.
Yeah, I mean, this is all about checks and balances, right? The physician, nurse practitioner, the provider is giving these instructions to the patient, but a lot of times these patients need some additional assistance. So having that gatekeeper, in the form of a nurse or other ancillary providers that are reaching out to the patient in real time through the continuity of care is really an important part of delivering good outcomes for the patient. At the end of the day, we want to reduce hospitalization costs, and we want to be able to provide that patient a good quality of life. And if we're able to meet the patient where he or she is in the comfort of his or her home, and being able to have the nurses reach out to these patients and connect to them like their family. I mean, that's how I treat my patients, like they're my family members. And we want to be able to, do the best that we can for them, setting expectations, making sure that they're accountable, but at the same time, being there for them when things are not going so smoothly. If we're able to develop those systems and the infrastructure to be able to identify those issues upstream, that can lead to better outcomes for the patient, for the practice, and for everyone else in between.
Absolutely. It might be just a question which the patient has after, seeing the provider. But then, seeing a provider, for a lot of these patients, there's also the generational thing where it's like a big event. It's almost like it's like the...
I mean, it's the highlight of their day. I know my patients always tell me that. They're like, Doc, it's been so long since I saw you. And, that really means a lot to them to see their provider, their physician, their nurse practitioner, their physician assistant.
Of course.
But at the end of the day, we only have a certain amount of time that we can spend with that patient. And really, it's important for us to be able to set up the infrastructure to be able to deliver continuity of care to the patient in between visits with the providers. So this is why it's essential to have these nurses who are able to connect with the patient in real time, understanding the nuances of their day-to-day existence, and being able to identify issues that may come up in between provider visits. Because I know for a fact that, I only have 15 minutes. And there's, certain things that you need to address in those 15 minutes. But at the end of the day, there are things that will be missed. And being able to fill those gaps with the nurses and the other support staff, that really makes a difference to the patient, because the patient feels that they're being cared about and they're being cared for. But really, at the end of the day, if you're able to establish that trust with the patient, the provider is able to outline what's happening in terms of, what to expect from the nurses and making sure that the provider is still the captain of the ship. That really sets the tone for the patient care.
Absolutely. And, human beings by nature, they want to hear what they want to hear. And especially when you go to the doctor, you hear what you want to hear and what you don't want to hear. Well, I didn't quite. Hence, the nurse can actually bring it back on the table. Hey, this is what was said. You need to get up and you need to go walking. I'm just using an example. But so it's very timely to have this kind of a conversation, in the context of chronic care, that you have a nurse who's going to be like making sure that, of course, if you didn't write it out in your summary, but if it's very clearly written, he or she's going to make sure that the message goes across, right? And take the time. Take the time.
Communication is essential, and really having detailed notes, is really important to ensure that the next nurse or next provider who is part of this patient's care team is able to understand what's happening with this patient. If there was an issue with medication adherence, for example, being able to custom tailor the interventions to be able to make sure that all the barriers are removed so that the patient is able to take his or her medication on time. So this is why it's so important to touch base with the patient on a routine basis. And I really do think that consistency is key. The patient knows that they will have to be accountable for taking care of themselves, but at the same time, they know that the nurses are there to be able to support them in their time of need. So this is why it's so important to set the stage right at the beginning. And making sure that all the members of the team understand their roles so that when things are not going so smoothly, that the team members are able to come in together, intervene, address the patient's concern, and make sure that we're mitigating any potential cost drivers down the line.
Absolutely. Absolutely. We actually use the term angel for our caregivers. But then an angel is like, it's somebody who's always watching. Guardian angel, right? And then you have your nurse angel who's watching over, making sure that you're good, you're covered. So I think that's exactly what we are able to do, and we want to put forward as the model. Let's talk a little bit about the big elephant in the room, which is diabetes. Tell us a little bit about care planning around diabetes.
Yes. Diabetes is a major disease state, and we actually have the tools at our disposal to be able to ensure that the patient is getting their necessary assessments on a timely basis. So, my grandmother was a diabetic, and I know that her day-to-day, being able to check her, glucose levels, 3 to 4 times a day, making sure that she had her equipment and the supplies that she needed to do that, making sure that she was going to the lab every 3 months to check up on her glucose levels and hemoglobin A1C, ensuring that she was connecting with her primary care doctor every 3 months, to have some further evaluation of her eyes and her heart and her kidneys and her, legs and feet. This is all part of the comprehensive care management plan for a diabetic. And I know this because I witnessed this as a child. And I know how labor intensive it is to be a diabetic. I mean, the day-to-day things that these folks have to do to take care of themselves, it's a lot. And especially for those who are newly diagnosed, I think that's such an important step to do good quality education to make sure that they're understanding the basics when it comes to day-to-day management of diabetes. I mean, I can't emphasize this enough. The providers, they are able to give the basics when it comes to medications and understanding side effects and being able to ensure that they have access to quality care. But day to day, this is where the rubber meets the road. These newly diagnosed diabetics have to have more care, and they need to understand that this is going to be a lifelong thing. And this is where the nurse and the care plan really comes into play. So being able to set those expectations for the patient, making sure that the patient knows that they need to have these supplies to check their glucose levels, making sure that the patient knows what to do when there's a hypoglycemic event. These are things that the nurse can provide to the patient in form of education, and also in terms of ensuring that the patient is aligning with the goals. And accountability is key here. If there are any hurdles or barriers to the patient being able to take the necessary steps to manage their chronic condition, this is where the nurse has the ability to really kind of step in. And, the care plan is a way where we can, have expectations for all parties, the patient, the providers, the nurses, and making sure that the patient is able to, still have a good quality of life, but at the same time, ensuring that they're able to take care of their basic needs.
Mm-hmm. So if you look at just diabetes with the care gaps, there's 168, and that's just diabetes. So each one of those care gaps is a possible crack in the wall, and the patient can fall through that crack and get hospitalized. So it is a major challenge to manage, right? Yeah,
but this is where, having that engagement piece, and we keep coming back to the engagement because that's a critical component of chronic care management. And being able to utilize technologies to understand the drivers behind a patient's behavior, and being able to continue to connect with the patient, finding ways to kind of get into that patient's brain, and being able to find ways to get the patient to be part of the process. This is a real thing. It's not just some isolated concept. This is really affecting this patient in real time. And we in the medical field know the potential ramifications of not treating a diabetic properly. These individuals might have diabetic ketoacidosis that will require hospitalization, that could potentially cost hundreds of thousands of dollars to society because of missing on those little details about medication adherence, and making sure that the supplies are there on time, making sure that the patient has the resources to be able to reach out to providers and, pharmacists and nurses when he or she needs them. So, it's accountability on all sides, the patient side, the provider side, the nurse's side, and the care plan is what keeps us all accountable.
Absolutely. So, of course, on our end, so we have the CCM, the chronic care management, with the care plan being centerpiece. We also have the RPM, the remote patient monitoring. You want to say a word on the RPM?
Yeah, this is the beauty of technology and where we're at in society in 2022. The fact that we have remote patient monitoring tools, so we can monitor the patient's vital signs, and even get those those test results in real time. And we can make clinical decisions accordingly based on that information.
Absolutely.
I mean, this is a game changer. I mean, for me, the last 2 years has been a fundamental shift in the way I practice medicine, because I have these remote patient monitoring tools now at my disposal. And we have set up the infrastructure to be able to educate the patients, make sure that they have the tools that they need to do these tasks, and then being able to integrate that information into the electronic health record so that when the provider, the nurse needs to have that information, it's readily available. So to me, this is something that will be here to stay. Patients like having these tools because they actually have some skin in the game. They can do what they need to kind of take ownership of their condition.
Of course.
And from the provider side, it speaks volumes because, you actually have some tangible data that you can use to make informed decisions. And, the data is already coming out that remote patient monitoring does yield short-term as well as long-term benefits to the carriers, to CMS. I feel like the more data that continues to accumulate over the next 5 to 10 years will make this even more of the foundation for chronic care management, that we need to incorporate these remote patient monitoring tools in our day-to-day activities.
Absolutely. Absolutely. And one word on on the geriatric population. So the product we have is, it's also comes with a nurse. So we have a nurse dedicated for RPM as well. Reason being, we are talking about a geriatric population. So, apps and stuff, although my mom is pretty good with it, but we don't want to depend on them starting to go on their smartphone and, making all kinds of maybe too many of steps. So we're talking about a device that's connected directly using cellular technology. And the technology end, we are taking care of what we expect is that they test. So we give them unlimited amount of supplies. We give them the devices, blood glucose and blood pressure, because the idea is to get data as much as possible. The more data we have, the more we can work with, the more our providers can work with. So, the whole point is to make it easy. And the word we use is seamless. And seamless for a geriatric population is to just have them test, and that's all. Not like having to log in this and that. So the device is already connected. So that is, I think, itself a game changer, right?
Yeah, press the easy button. Making it easy for the patient to use the technology is vital, because otherwise, if there are too many barriers to using the device, chances are the patient will not use it and it'll just be sitting on a shelf. So, this is where it's so important, especially with our geriatric populations or non-English speaking populations, trying to make things simple, easy to follow, not too many steps, and we can still get reliable information. That's really key.
So I was speaking to an endocrinologist this morning who went to a conference. So fresh news, which is, there's always a fresh news. So 1 out of 2 Americans is expected to be obese and prone to diabetes in the next decade, which is 1 out of 2. So
yeah, that's just mind-boggling. I know, we've been seeing the growing trends of obesity in our country over the last 30 to 40 years, but unfortunately, we have not been able to break that cycle. And I think this is why it's so important to be able to understand the drivers behind a patient's behaviors, because at the end of the day, it's all about behavior. What leads to obesity is behavior. And being able to identify those triggers that are causing that individual to resort to food, I think it's so important to be able to kind of take that into account. And then this is where the care plan really comes into play. Being able to identify those triggers, being able to do the month-to-month assessments, getting that BMI, but also understanding that there might be some other socioeconomic factors at play. A lot of our patients don't have good quality to high quality foods. So being able to kind of understand, the day to day, what is this person eating? What is this person doing in terms of physical activity? Being able to kind of calculate that basic metabolic rate, being able to understand that this person, has a certain caloric requirement, but due to circumstances may be exceeding those requirements because of X, Y, and Z. This is where, you need to have an individualized care plan. You can use the standardized ones to kind of give you the basic roadmap, but every patient especially given, the data that we've been given on obesity, is going to require specific custom-made formulaic plans that are tailored to that individual, and being able to understand those drivers to hopefully kind of turn the tide on these alarming statistics.
Absolutely. So that was the last area I wanted to talk to you about, but you've already touched upon it, was the model of gap analysis and gap closure and individualized care.
Yeah, so this is really where it's so important to be able to, understand where those gaps are. And, this is where the nurse really kind of has that major role to play. If we're finding that the person doesn't have, a grocery nearby where he or she can get fresh fruits and vegetables, that's important to document. And then being able to understand, how the person can find alternatives. Does that require getting a family member or a neighbor involved? Does that require utilizing a meal service plan? There are a lot of solutions out there, but if we're not able to identify the problems, then we can't find the solution. And this is why it's so important to have a well-engaged nurse who understands these patients, speaks their language, understands the culture, is able to kind of make that direct connection with him or her. And at the end of the day, that really will yield, changes in the person's behavior and will yield to better outcomes in the long term.
Absolutely. We can talk about care plan sharing. That care plan, can be, there's one provider, but there's, other doctors that the patient sees that has not seen. So the idea is to also, that's maybe for another podcast, we'll go into that. There's also what happens when we close those gaps is quality goes up. And then we see value. And when we see value, we are able to see a very direct influence on cost savings. And at the end of the day, we have to be able to show that the model that we have is able to translate into cost savings, because that's a very direct way to gauge, even for us, that we are actually on the right track. We are doing good work, being able to actually drive down those costs. Because at the end of the day, we want to be able to, bring that, the value up and the cost down. In order for that to happen, quality has to go up. And in order to have quality, we need time. And physicians, one thing they don't have is time. And so it is kind of like a gift of time, isn't it, Dr. Berenji?
Indeed. And you really nailed it. At the end of the day, it's about being able to utilize the time that we do have to really, meet the patient where he or she is, and finding ways to develop that support team, the nurses, the pharmacists, everyone who's involved in taking care of this patient and taking the time, whatever time that we do have allotted, to identify those care gaps, to identify those barriers to good quality care. Every little minute counts. And if we're able to utilize that time wisely, at the end of the day, that's what matters. The patients do resonate with that. And, they always want to be able to work with the doctor, work with the nurse practitioner, work with the nursing team, to be able to, have that quality of life that they deserve. So at the end of the day, time is always a precious commodity, but we have to use our time wisely. And having these support teams that understand their roles, understand the expectations, and are able to connect with the patient, that will yield good outcomes. And I'm very confident that over the next couple of years, we'll start to see even more of that.
Excellent. We are almost out of time. I think we are out of time. So, Dr. Berenji, thank you so much for joining us today to talk about...
Thank you, Dr. Jayaswal. It was a pleasure.
Care planning. So we will actually come back in 15 days and talking about sharing of care plans. We'll be having a cardiologist, Dr. Tejani, who will use 4 or 5 case examples about how care gaps are closed. That should be pretty fun, and I will keep you posted on that. And our viewers, please join us in 2 weeks at the same time, at the same day, same time, and we will actually have another podcast for you. So until then, I'm Dr. Avinash Jayaswal, Chief Medical Officer at CCM Health. Thank you, and have a good rest of your day, and stay safe. Dr. Berenji, take care.
Thank you.